Uh, Warm welcome to everyone in this webinar on Introduction to Clinical Postings. So before we begin, real quick, I will be reiterating some etiquettes for the meeting. People, keep your mics muted, turned off whenever you are not speaking and whenever anyone else is actively speaking. However, you are encouraged to turn on or unmute yourselves whenever a speaker is taking the talk interactively and also during the question and answer slot. Videos could be kept on or off according to your choice and convenience. However, it is encouraged to keep it on to make the session more interactive. Inappropriate words should not be used or should not be heard in this meeting, or any disturbance if is heard, that attendee will be removed from the meeting immediately. As stated above, some time at the end is allotted for audience questions and doubts. If you have any question during the webinar, we request you to note it down so as to ask it whenever the time is given. You can also put it in chat box, or if you are watching this webinar on YouTube, you can put in comment section or live chat. We will convey the same to the speaker. So with this, I will like to hand over the things to Dr. Shraddha More, ma'am. Ma'am is MBBS, DNB, General Medicine, MBBS, MD, DNB, Internal Medicine, Assistant Professor at Department of General Medicine, SET, GSMC and KMH. Over to you, ma'am. Ma'am, you're muted.
Yes. Can you hear me?
Yes, ma'am. Yes, ma'am. You're audible.
My presentation, can you see?
Yes, ma'am. It's visible now.
Yes. So, good afternoon, all of you, and welcome, all of you. Myself, Dr. Shraddha. Harsh has already introduced me, and I would like to thank Pauras and Harsh, both of you, especially Pauras, to give me such a fantastic opportunity to be with all of you. So, you people are in second year now, all you students, and you are about to enter into the clinical world soon. So, let's go into the wards then, all of you. So this is a wonderful pic of my last posting of my final year students. That is how we do at the end of the posting, and you can see the smiles of knowledge that they have gained over the entire posting month, and the satisfaction on their faces, on my faces. So basically, what are the clinics and why you want to attend it? So whatever you have learned in your first year, anatomy, physiology, biochemistry, a dilemma, especially in the subject of biochemistry, you must be having is it real? सच में ये ऐसा होता है क्या? So yes, it actually exists, and medicine is something which is real. And whatever you have learned, students, you are going to see each and everything when you are coming to your second year onwards and entire third, fourth year. So basically, that is one reason why you should attend clinics and what are going to be the clinics. And it is going to make you a better physician, a better bedside physician. You have to get into habit of seeing a patient, taking a history, listening to a patient, having observation and picking out those tiny signs from the patient and giving a diagnosis. So unless you attend clinics, you are not going to get perfect at that. Then a conversion of theory to practical, that is what only clinics is going to do. And I always say that there is a brain eye brain loop. And what do I mean by that? When we are sitting in the libraries of say GSMC, KMH, or any medical college all over the world, we are putting everything in our brain. But then the same thing, when you are into the wards, you are going to see the same thing. You have to see the things, to understand that yes, such things are there and how they look. You read about jaundice, and when you really see a patient of jaundice, it becomes very beautiful. And then again you go back and read about the case. So that is a loop which I follow. So read it, see the patients, and again go back and again read about it. So this is something which I want all of you to follow. And then whenever you are going to come to the ward of or the world of clinical medicine, you are going to meet many brilliant physicians, brilliant surgeons, brilliant bedside clinicians. So that is something. Take the good points or take the good habits from those stalwarts. I will I will advise you. And then, other than the medicine, you are going to learn something related to humanity when you are going to attend clinics. So that is something which I call it as a sickness and relations. I do write some small stories on sickness and relations. So basically, you are definitely going to be a better human once you attend clinics, you start seeing patients, you start listening to their stories. So these are few reasons why you should attend clinics. So when you are going to get posted in particular department, and I'll talk about medicine. So what all you are actually going to do in the medicine posting, what all you will see. So first and most important thing is case presentation. So you have to do the case presentation on your own. Then you are going to see the OPD patients. You are going to see the IPD patients. You will have some emergency visits. You will see some critical care patients, and then some lovely procedures you will be able to see. Sometimes, maybe if you're lucky enough in your final year, you may assist also those procedures. And then there is, in medicine exam, there is a part which is Viva. So we do take those Viva tables also in your posting. We try to cover those as well. So these are the things which we are going to cover for you in our medicine posting. Now, what all departments you people are going to get posted second year onwards? So you already know all the subjects in MBBS. So basically, the main departments, preclinical and clinical departments, so ENT, ophthalm, PSM, and then med surg, OBG, peds, anesthesia. So there are few departments, plastic surgery and dermatology. These are the departments you will be posted. So how the particular department functions. So whenever you see any department, when I'll talk about medicine, there is a OPD, which is an outpatient department where a patient comes on that particular day, and then we see the patient. Like, let me give you an example: a patient of diabetes or patient of hypertensive, he comes, we see the patient, we write up the prescription or we refill the prescription, we check the BP, and we send the patient back on the same day. So that is something which is a OPD. So that is one level of care which we have. Then we have something which is a daycare as well, which is where the patient is admitted for maybe few hours, and then we discharge the patient by the evening. Then there are IPD, where the patient is little bit more sicker, or do not have a diagnosis when we see the patient for the first time in OPD or emergency, and we cannot send patient back home just like that without diagnosing or without treating the patient. That is the time when we need to admit the patient. So that is the time when we need to admit the patient, and that is called as a IPD, inpatient department. And KM and most of the hospitals, they will be having a beautiful IPD patients. Then there are community services. Madam will talk about the community services. So these are how the department, any department functions. Then there is emergencies there, critical care is there. Other than doctors, other four pillars of why we can run a healthcare so beautifully is we have nursing staffs, we have the mamas, we have the mousies, and that is why we can do it together. It is a work which can be done only and only by a team of people with a complete dedication for the work. So coming to the unit system. So when you are going to get a posting, for example, if you are getting a posting in medicine, in KM or in any hospital, you will be posted in particular unit in that department. So now in medicine of KM hospital, we have 6 units. So there will be 6 head of the units, and you will be posted in one of the units. Suppose, let me give you example of my unit, which is a MY Narkar unit. So what a units consist of? So a unit will have a head of the unit, which is either a professor or associate professor. Then there will be a lecturer or AP under that head of the unit, and there will be a SR or just pass out MD student will be there. And then there are residents, third year, second year, first year. So that is something which is a unit which is handling admissions on that particular day of the week. Okay, so you will be posted in particular unit, and there are all the units in all the departments. They are wonderful units, and you are going to learn a lot from each unit. Okay, it depends on us what we have to learn and how much we have to learn. Always remember this. So basically, how many postings you will get for that particular subject, it varies, but major subjects like medicine, you get 4 postings. And the schedule is sometimes it is changing because your curriculum is little bit newer, the CBME curriculum is coming, but generally there are 4 postings. And how to go about these postings? So getting which unit is always an anxiety. Monty sir will agree that. So getting a unit is always an anxiety for students. Which unit I am going to get. But that is something which is a luck and it's a lottery system. All right. Okay. So once you come to medicine, so what is that systematic way of learning? A student of second MBBS who had just passed first year and then first day of your medicine posting, and if you say that I want to take a case of a multiple sclerosis and present it, no, a big no for that. So you have to be very systematic. Okay, do not mess it up. So how I will advise you, you go from a symptomatology history taking and read each and every symptom in detail. There is a beautiful book in NCBI bookshelf staples. We'll share the link of that with the group. So that is something, if you start in second year itself, then only you can finish it off till your final MBBS. You cannot start that later in third or final MBBS. No. So this is your time. Go for it. It is very much in detail and one of my favorite books. So what do I mean by symptomatology? Suppose in cardiovascular system, chest pain, breathlessness, syncope, palpitation, fatigability. So these are the symptoms, and I will study in detail what all can be the differential diagnosis of a chest pain patient, or how I should work up a case of a chest pain. Okay, so that is how the symptomatology is there. Then examine after you are done with your symptomatology, and you have to finish that in your second year. Do not leave it for your third year or second posting. Then examination, try to finish off your examination techniques. When you are in first year and in physiology, it has been already taught to you how to do the examination, but then again now you have to apply the same techniques in a little bit different manner. So try to do this in a correct format under the observation of your teachers, your residents, and interns. कि ये सही है कि नहीं, okay? And finish it off in your first posting itself. Fine. Then once you go in your third year, once you are done with your pathology and all, then once you start taking cases, that is something which is you will start understanding how actually I have to take a case of mitral stenosis and multiple sclerosis presenting as paraplegia. In second year, you may not be perfect, correct? But then later, slowly, you will understand. And then as you are in final year, again, you will keep continuing taking the cases, but then there should be a addition of recent advances and the newer guidelines that you have to put that cherry on the top of the cake. You have to put it, the recent advances is something which really gives you that D that you want in your results. So before entering the world of the bedside clinics, make sure that COVID तो हम सबने लिया हुआ है, but make sure that you are vaccinated with hepatitis B with 3 shots, and then your titers of antibody to the surface antigen is good, and even the tetanus shot is something which is very important. Why? Because suppose if there is HbA1c positive patient and there is you have a cut in your hand and you are palpating, or he is presenting as a jaundice, you wanted to palpate for the liver. What if something happens? So that is why it's better that you prevent it. Fine. Now, what do I need to carry when I go to my clinic? Wear a good apron, clean apron, preferably long hand. If you don't have long hand, that is not a problem. Stethoscope is very important. I will tell you, if possible, you can carry a Littmann, but it is not necessary. If you cannot afford it at this point of time, not a problem at all. Okay, it is a saying that what is there between the ears, that is something which matters, and that is something which interprets. Okay, so be it a Littmann or be it non-Littmann, doesn't matter. All right. Okay, but your ears should get the habit of listening. Many times it happens that in final MBBS, then students get depressed कि मरमर ऐसा सुनता है, S1 S2 तो सुनाई दे रहा है, S3 S4 नहीं सुनाई दे रहा है. Why? Because you have to tune your ears. It is something which is practice, practice, practice. Correct? All right. Then you need to have a torch, hammer. Hammer is extremely important, especially your neuro clinics. You have to have a hammer. And then again, there is confusion which hammer to be taken, whether CMC Velour hammer to be taken or this simple hammer triangular. I will advise you take this triangular simple hammer for undergraduate level. Gloves is important for your personal protection, and then CNS and RS kit. So we will let you know what all things are there. It is a detailed list of some 30-40 things which has to be kept in the neurology kit, and some 10 things which has to be kept in respiratory system kit. Okay, so I will make sure that I will give you the list of both the kits. All right. Protection, very, very important. Do wear a mask, be it 3-ply, N95, whatever you're comfortable with, that is okay. Gloves are important, especially when you're examining the patient. And hand wash, protect yourself and protect the next patient from spreading the infection. Which books to read? It is a very, very difficult question for me to answer. Very difficult question, because there is no perfect book as such. But yes, Harrison goes on top of the list always. But these are few books which are not bad, I will say. But my favorite, as I said, for symptomatology is that NCBI Starple's book, which I will share the link of that. And other books are, Kundu has given good case formats, like Approach to Case of Paraplegia or Hemiplegia. Then Hutchison is a shorter synaptic type of a virgin book, which is not very much in detail, but it is a good book. And Davidson for theory you can read. But if you really want to go in detail and learn your basics, go and read up Medscape up to date. And even today, all you I don't know whether you believe or not, whenever I see any case, I go back and open my Robbins pathology and I read up. If it is a case of NMO, what is that aquaporin? Why that aquaporin antibody has come? So that is how you have to go back. You have to go back in the history and make your diagnosis or make your medicine wonderful. So these are few books. Other than that, as I said, the NCBI, I will share the link. So now suppose कल से clinic हमारा चालू होने वाला है, posting क्या करें? So I believe that my next day is starting a night before. So I am a person who writes a planner and I know how I am going to spend my next day. So do write, make sure that you make a habit of writing a planner a night prior. And in context to this clinical posting, so make sure that you know what case you are taking. Many times what happens, students will start taking or searching the case on the same day itself in the morning, and then the entire things, consultant does not know what is the case. So that is something which is not a good habit. So take a case a day or two prior. Inform your consultant that Dr. Shraddha, I am going to take a case of a hemiplegia tomorrow or day after tomorrow, so that you will read, Dr. Shraddha will read, everybody will read, and it is going to be 100% good clinic. Correct? That is what, because even we tend to forget, So the final points we should not miss while teaching you. And then I often make an online WhatsApp group of those 15 students, 30 students, and for a better communication and schedule. And make sure that you come on time. Make sure you come on time, and those 3 hours you utilize it. Many times I see that students are sitting in the side rooms because consultants are taking rounds, consultants are coming late, and then you people are doing something on your mobile, something is happening. So क्या करे इस time का क्या करे? Who is holding you back to go towards? Just wear your apron and go inside the ward, talk to patients, see the files, and just explore the world of medicine. Nobody is holding you. Okay, fine. So that is all. And can you come in the evening? If is it allowed? Definitely it is allowed. Definitely it is allowed. In fact, I tell students from private medical colleges also, if you do not have the cases in your hospital, just wear an apron and come to the government medical college wards. Nobody is going to recognize you. It's just like a Three Idiot movie scene. We just need uniform, nothing else. Okay. Yes. So this is one of the tasks which this is just out of the thing, but this is one of the tasks which you people have to do. So there is a Pareto principle. You must have read about Pareto principle. So take 20 chits, write things, what 20 things you do in a day, and then analyze this. How much time you are spending on what task and how much results you are getting on those tasks, and you won't be surprised to see that you do fit into this Pareto principle, most of you, and start working how we can get better. Coming back, so vision board for the posting. We have vision boards. We have lots of vision boards. Make a habit of writing a vision board. But what is my vision board for my clinical posting is I should have what cases I must see. And these are the cases from Department of Medicine. You should see, you must see. I am going to share the PPT with all of you. So MSMR, ASAR, ASD, VSD, TOF, effusion, pneumothorax, COPD, ILD, fibrocavitary lesion, hemi, para, ataxia, quadriplegia, that is GBS and ATM, hepatosplenomegaly, jaundice, ascites, CLD. You will not get any case other than this. Maybe one or two, maybe anemia can come up, goiter can come up, but then they are covered in surgery as well. All right. So these are the cases. Write up on your vision board. Don't skip a breakfast and come to clinic. Never ever do that, all of you. Okay. Eat a good protein diet and come to the clinic. Sleep adequately. You're a med student. That does not mean that you should not sleep. But why we do not sleep is because of this reason. So this is something again we have to work on. Correct. So technology, somebody has said it is a very, very terrible our great servant. And I'm going to give you some tips. So that was Stephen Covey, sir. Before reading, I always tell my students, अगर hemiplegia का case present होने वाला है, you read up hemiplegia. And when you want to read any particular slept fresh brain, जो भी सबसे important है, बाकी बाद में आप पढ़ सकते हो. And then there is something called as then एक हमेशा कंप्लेंट होता है अरे मेडिसिन में कल पड़ा, बाद में कुछ भी याद नहीं आ रहा है, दूसरे दिन नहीं याद आ रहा है. So this is how you convert your long term to short term, and then making 7, which will take a minute. Listen to audio note on day 14, which will take another 2 to 3 minutes, and then there is something called as a smart card, which I'm going to show you. That is something which you can read on 30th day, and that is how you convert it into the long-term memory. Many of you will be localized. You will be traveling to hospital daily for attending clinics, and then this is a dream for everybody, correct? But is it possible in India? No, it is not possible in India for a common person or common man or common people like us. And that is why what you can do is you can make your audio notes. I am going to share one audio note or 2 audio notes of multiple sclerosis and myasthenia gravis, which I have recorded, and I do listen to them. So that is something which is important because हमारा समय बहुत ही कीमती है. Okay, so I will send this. Now we do not have time to listen to this multiple sclerosis audio note. And then I said on 30th day, you can just revise a summary card. This is how you can make a summary card. So this is like a very beautiful, colorful card. And this is a last day revision card because you cannot read the entire chapter. So make a habit of making this. Whenever you are going to posting, make sure you are dressed properly, you are dressed comfortably, you have a clean apron, you are clean shaved, nice shoes, no chappals, no paragon, okay? Have a hanky with you. If you have a name on your apron, that will be fantastic to, patient to know. And then whenever you are communicating, don't be very still. Communicate with your head nodding is something which is important. Make a eye contact, but do not embarrass the other person by having a detailed, continuous eye contact. And do smile. Because smiling does not cost anything. That is why. But gently, okay? And patient से कैसे है बात करना हमें. Introduce yourself. I am Shraddha. I am second year. I am Pauras. I am second year student. Now he is in third year. So then remember that they are sick. So do not expect, that maybe they may laugh, they may smile, they may talk to you nicely. It's okay. It's okay. Be empathetic towards them and reassure them that whatever you are asking them, personal, private, many things you will ask, sexual history will ask, that is reassure them that it is only and only for your clinical purpose. Okay, and consent is must. If it is no, it is no. So consent is something which is must, and patient do give consents. Okay, but they have maintained their privacy as well. Respect that. Observations. Observe the patient. I often play a game with my residents. Whenever I see the patients, I before they are starting and telling me the history, I just give the diagnosis. Many times I'm wrong. Many times I'm wrong. But whenever after 100 spot diagnosis, when you get 10 to 20 correct, by now I get 60 to 70 correct. So that is something which is I have developed over a period of years. So that is something which is observation. So there are few observation exercises also, which maybe I will tell you some other day. You can contact me from, take my number from Pauras. All right. And when the posting is ending, it feels very bad when posting ends and you people leave. But we have to take an exam before that. So we do take a end post exam. And I think the marks have been changed to 15 marks. So there is going to be long case. Generally, either a single student takes or a group of 3 students take. But it depends on every unit's, how they want to take the exam. And then what do we see or what do we analyze in the exam is how you are actually performing the examination methods. How are you doing the plantar, ankle, and knee reflex? How you are going to do the splenic palpation and percussion methods, correct? And then you do master your skills, as I said, on daily basis. Do it in front of faculty. Dr. Shraddha, please, can you stand here? I just want to do the ankle reflex, please. Yes, I will be there, show it to the intern, show it to your batchmates. Never hesitate to ask. Okay, because if you don't ask, we will not come to know what you have not understood. So please ask. Even if I don't know the answer now, I will go back, I will read, I will discuss, and I will come back to you. That is our promises to you, because today's master was once a beginner. You people are beginner, and within no time, you people are going to master the skill. But your time is very, very limited. So this is, you have to be very smart in choosing whom you want to spend that time. And this applies to your clinical posting as well. Okay. So don't be the victim of environment, be the creator or architect of it, and be in a culture where your desired behavior is a normal behavior. So practice that tribe concept, where be a part of an ambience where you have common goals. Okay, do attend lots of seminars, workshops, try to present cases, do not hesitate. Language is an issue, not a problem. It should not be a problem for your whatever knowledge you have. Okay, it is just a method of communication. Fine. So that is something which is important. Mentor, always get a mentor, always get a mentor. So luckily in KEM we have a very strong mentorships, and Dr. Monty is there in surgery, and we have many people. So do have somebody, and then these are few mentors, and we do have on and off. We had kept a final game for final year students, how to play the final year and just get that gold. So everybody is from KEM. Few are currently not there except me, I guess, but they are still in touch with students, and we do keep lots and lots of things. So do stay connected with us. So I will just say that mastering any skill you can just do by practice. It is just, and you will start loving it. But you have to take an action. So this is how we imagine a finale student or a medical student, correct? But then we should not worry, or we should not get bothered with this, because this is something which we are going to achieve with the hard work, with the consistency, with the determination. And that's it from me. Thank you so much. I hope that I have stick to my time.
Thanks a lot, ma'am. It was a really beautiful presentation, and I think now we all are oriented to the hospital environment. And now it's time for us to move from hospital environment to community. So I hand over the mic to Dr. Sujata R. Lavangare, ma'am. Sujata ma'am is MBBS MD PSM, DPH CHA TISS. Ma'am is Associate Professor at Department of Community Medicine, St. GS Medical College and KEM Hospital. Ma'am, you can unmute and start.
Good afternoon to all of you, and congratulations to Pauras and Harsh for the excellent efforts taken for this webinar. Harsh, can you display my?
Yes, ma'am. Just a minute.
So, after a very lucid and a very wonderful presentation by our speaker, Dr. Shraddha, I move on to our presentation with regards to clinical postings in community medicine. So as you all know that, each and every patient who comes to a tertiary care hospital like KM Hospital, Nair Hospital, Sion Hospital, all the other hospitals, they come from the community, they come from a family. And family is the main unit of the society, of the community. Hence, today's presentation mainly tells you about the clinical postings or immediately after the first year student enters the second year and starts the first clinical posting in community medicine. Next slide. So, to tell you briefly about this first clinical posting, this posting is mainly for 4 weeks and it is just starts as the student enters the second year. What is very mandatory is that the student should have a logbook, a family journal, and the biostatistic journal before starting their first clinical posting, and you will get it from the Department of the Community Medicine. Next slide. So let us understand what are the main domains. What is actually we look into this posting. There are 4 main domains like the family visits, epidemiological history taking, institutional visits, practicals. So these are the 4 main domains. So let's come to each domain. So next slide. So as I told you that each and every patient who comes in the hospital comes from a specific family, from a family. So what we are doing here, we are trying to understand the connection or you can the networking or the linkage between the community and the hospital. And for that, as Madam has said earlier, Shraddha Madam, how to look into the patients or to get the cases, okay, how to see the cases in the wards, in the OPDs, in the hospital. In the same way, we are now going to enter a community or you can say the enter into a family and understand how to conduct these visits. So before conducting the family visit, it is not that you all directly sent for the family visit. The first and the foremost is a proper orientation lecture. It's taken on the family visit by a concerned faculty, and there are 3 family visits. So on the very first family visit, a proper orientation lecture is taken, and at that time you should have your family journal. And as I have confirmed, all of you have received your family journal. And I'm sure before this webinar, you must have gone through the pages, the first important 20 pages of the family journal. So on the very first day, you're oriented about what is a family, the definition of a family, the types of family, what are the things you have to look when you, or you have to actually observe, what you have to grasp, what you have to write down in the journal, and what history you have to take when you actually go to the family visit. So they are taken in a proper vehicle accompanied by a community development officer, a senior resident or assistant professor respectively, and one family is allotted to 2 to 3 students or max one family to 2 students. Next slide. So now what is the most important thing to be done during the family visit? First one, most important, you have to build a rapport with the family. And that's why there are 3 family visits. Other reason for having 3 family visits is since the data you have to collect is of having different dimensions, and hence that you have a chance is given for you to go to the second time and the third time. So there are 3 family visits, and you have to see the other points like assessment of housing and environmental conditions, assessing and identifying the health problems in the family, the entomological survey, and filling the journal. So these are all the important points which you are supposed to do when you are actually doing the family visit. And this all will be explained to you during the orientation. There is a 1 hour lecture for you during that process. And of course, even during the visit, you are accompanied by the community development officer, even there is one assistant professor or a senior resident. Each one of you, each one of them is there for you there to address your immediate queries or immediate issues whenever you are there in the community. And now what is done after during this family visits? Following things will be discussed in the classroom. So what is discussed? The health related issues. So each and every student or the students who are allotted a family have to tell or discuss their family issues or health related issues in the family. And based on that, about discussion, what IC material needs to be prepared, or IC means information, education, communication, or the health education material. What importance, or if suppose in a family you see a few cases of diarrhea, okay, or a case of typhoid, waterborne diseases. So, or there is a case of respiratory infection. So, with regards to that, or non-communicable diseases like diabetes and hypertension. So, with regards to that, you have to explain your family health issues and health education material, or health education will be imparted to the families by the students. Okay, all this will be taught to you and will be explained to you. Next, please. So now you have gone through the journal, I'm sure, and since the time is limited, I just highlighted the most important points which have to be filled in the journal, like the general family data, like the name of the head of the family, the number of members in the family, the per capita income, the expenditure, the socio-economic data of the family, general family information, the names of the members of the family, their age, the relationship to each other, okay, all these important points, socio-cultural practices in the family. You know, there are many myths and misconceptions, and for example, when a child is born, there is a culture of applying kajal to the eyes. Okay, or you can say other myths and misconceptions is like the newborn baby is not given colostrum, which is the very first milk or the first immunization which is given to the baby. That is the first breast milk which is given to the baby, because it is considered not good. Okay, or during the menstrual cycle, a female is made to sit differently due to the myths and conceptions. So the scientific reason is maybe she's having a little weakness due to the blood flow, heavy menses. So, but the reason becomes different. So due to this myths and misconceptions, which we have to understand, and this affects the health of the concerned patient or the concerned family member. And hence, it's very important for us to understand the socio-cultural practices in the family, and that you have to ask and fill in the journal. And data and reproductive and child health, okay, the obstetric history, the infant's history, the data on the family planning services, the infant schedule. Now, it may so happen that you are allotted a family and there may be no infant in it. Okay, you are allotted a family and there may be no pregnant woman there. So it's fine. You have to just keep that part empty. But then you can always ask your colleague or see a family which is having a infant or a pregnant ANC mother, and you can understand during the discussion from that colleague of yours during the classroom discussion or during the discussion in the community. So advice given to the mother of the under 5 child, the diet sheet. So this is very important activity, you know, diet sheet. So it is combined in this family visit. There is also another activity like taking blood pressure and body mass index, you know. So means like during the family visit now, due to the CBME curriculum, there are some changes. Then in the Hello? Hello, am I audible?
Yes,
You're
ma'am.
audible now.
There was some connection issue probably.
Am I audible?
Yes, ma'am. You are now audible. I will go
Oh.
to the PPT.
Uh, the most important part is the summary of the family, the highlights or the positive points, the important socio-cultural practice which you have seen in the family, all these important points, any specific diseases you have seen in the family, you have identified in the family, that you have to mention in the summary.
Hello.
No, I guess ma'am has lost connection again.
Yeah,
We'll just wait.
I'll contact him.
Till that time, anybody wants to ask any questions, they can ask. I can answer. Till the
Yes,
time.
that would be an amazing use of time in the meeting.
Yes. Yes. Anybody shoot out? Come on. Keep your video mode on. Let me see you guys ask questions. There should not be any fear component in any one of us.
Like ma'am already has spoken. Like you should not hesitate. So you can start it right here itself.
Especially the KM people. Okay.
Also, guys, come on. When we were going in second year, we had so many questions about clinical postings because we didn't know what to do. So this is a chance to ask those questions. You can even put them in the chat box.
If not questions, just something else. Just talk about something else till she comes back. What are your worries when you feel like, when I'm going to go to clinical posting? What do you think? Tell us. Let us know. Now I'm going to call up the names. Okay, don't leave the meeting. I'm not going to call up the names. Okay.
Also, what we can do in the meanwhile is like Harsh could like share his experiences on the postings.
For us, madam has rejoined.
Ma'am has rejoined. We'll restart.
Hello.
Yes, ma'am, you're audible.
Yeah, I apologize for the technical, some error was there. So it's this family visits are conducted in our field practice area of our institute or Department of Community Medicine, that is a Naigaon community. So like if you go in the family and if you identify that there is a case of diabetes or there is a case of hypertension, then you can actually refer that patient or that member of the family to our community OPD or the chronic OPD in the community. Or if there is an infant and the child is not yet registered in the under 5 clinic. So we have our well baby clinic in the Naigaon maternity home from the Department of Community Medicine. So the child can be referred there. So it is very important to follow up in the family where this referral is actually done and how is the patient progressing. So it's very important the family follow up. Next, please. So now let's come to the good community practices like the GCP or the good community etiquettes. Like Madam has told you earlier, that take a proper breakfast before the visit. So it's very important to take a proper breakfast, wear an apron preferably with the institute's logo, carry your institute's identity card, be polite and take permission before entering the house of the family, remove the chappals and the shoes outside. So it's actually, what you expect if somebody comes to your house. In the same way, you have to behave there. Introduce yourself and explain the purpose of your visit. carry a small diary or a notebook to write down the important points and then enter them in your journal. So that is very, very important. And for any query at that point of time, we are always there. The community development officer is there, the assistant professor is there at that very moment. So you can immediately come to them. For example, if you go to a family and the family is locked, the house is locked, so naturally this CDO or the concerned assistant professor will give you the different family at that point of time. So that issues will be solved at that point of time. Next. Next, please. So next domain is the epidemiological case taking. So this is very important because you are oriented about how to take a case. Now, you must be taking reference of different books. Like I think there's a important book like PJ Mehta where there is actually how to take a case. But in this here, in the case of community case, you have to take with the epidemiological point of view. And for that, all these points will be explained to you during the actually how to take the case. Means you have to identify the source of infection. So which cases are given to you, like tuberculosis, fever, STD, HIV, diarrheal diseases, etc. So what is very important that before you come to take a case, you have to actually do the reading part. So once you read about the disease, the agent, the vector, the source of infection, the transmission, the communicability period, the incubation period, all these things become clearer when you actually take the case. So I suggest it very strongly. In fact, it is really mandatory to read a case before, and these timetables of the concerned case taking are actually given to you beforehand. So you already know that this is the case which is going to be taken for me. So for our class, so you have to actually read it. So when you actually come and present the case, it is more easier and you will grasp it more, absorb it more. Next. Then the other most important domain is the institutional visits. Like these are the visits which are organized by the department in networking with the concerned authorities of that institute, proper timing and the proper what you can say, meeting is done with them, talking is done by telephonically, and proper timetable is prepared with regards to this institutional visits. Like the City Disaster Management Institute, there is the NRC, Nutritional Rehabilitation Center, Hafkin Institute, then there is the sewage treatment plant, public health laboratory, visit to Kasturba Hospital. So all these are the institutional visits. So these visits are very important. In the case in the Hafkin Institute, if you go, what is really shown to you is the antiserum preparation, then the entomology, how the vaccine is manufactured. So these are the important points which are shown to you during the visit. So it's very important that these all visits are entered in your journal. You write down the important points. Now all these things, like all these visits regarding sewage treatment, if you see, this theory is given in the textbook of Park's textbook of preventive and social medicine, which we recommend for the UG students. And you have to read about this sewage treatment. So once you actually go to the treatment plant, you will understand it more better because there you are seeing it visually and then you correlate with what you have read. So it is very, very important that you read about the sewage treatment plant or the visit to Kasturba Hospital, which is an infectious diseases hospital. So there, these all visits have to be entered in your journal and they are very, very important. And you will be accompanied by the team. Next. Then next is domain is the practical. So there are some most important practical is the entomology practical, and there will be other practicals which will be involved in the other, what you can say, the other trainings. What you can say, the other. Just one second, excuse me. Sorry. During the other postings, like for example, the family planning or the contraceptive methods. So that will be incorporated in the other postings. So this is one of the important practicals, like arthropods of public health importance. So identifying them, the microscopic identification. It is very important that you enter and draw diagrams in your journal. And basically, most of this are kept in the spots in the exam. So you have to be, you have to read it and come for the practical. So if you actually the theory lectures are taken for you, and then you have to read and then come for the practical, so that you can absorb them more faster and you can even recollect them. Next. So the important highlights of this presentation, which I've just shown to you, is the good community practices, self-directed learning. Now you see what you this according to the new curriculum and the self-directed learning. I'm sure you have heard this word. It means like suppose there is a lecture on anemia. This is a topic given to you. So basically, you have to read about anemia. Your team, your group has to read about anemia from the concerned textbooks or the reference materials given by the concerned faculty who is going to take the lecture. And then uh, you will be presenting to the concerned faculty, and then based on the inputs given by the faculty, you will make the concerned changes. There will be an interactive discussion. Okay, so here it's like you yourself have to take the initiative by trying to prepare a presentation or taking means it is sort of a quiz, you know. So this is very, very important. Next is the reflection writing. That is what you have learned from this uh, concerned lecture today, or what you have learned from this visit today, what you have learned from this biostatistics lecture today, or this epidemiological case taking today. You have to write a proper reflection, and you have to write all this in your journal. So it's very, very important. Other most important thing is attendance. So please attend all your lectures, all your visits during your clinical posting, because it's very important, because these visits, these lectures are arranged with a lot of efforts and they are specifically for you. So please don't miss these visits, attend them regularly. Reading before coming for the practicals or coming for taking a case, please read, proper filling of the journals and taking signatures of the concerned resident and faculty during that time itself. So this is very important. Next. So the beginning is the most important part of the work, and hence you have to, since I'm sure after showing you all the slides, you must have basically understood what is the first clinical posting, the 4 weeks of the clinical posting, and how very important it is. It is like a basic foundation, okay, of your other postings. And of course, after the end of the posting, there will be exam for you. So that is the exam after this clinical posting, which will be a case viva with the grand viva. So and that basically how much you have assimilated, how much skills you have developed in how you have taken, means applied your skills in taking the history taking in the community. So all these things will be seen during that exams. So all the best to all of you. Hello.
Thanks a lot, ma'am. I'll stop sharing my screen. It was a really insightful presentation.
Hello, Harsh. And
Yes,
Pauras, I will have to leave for a important meeting
Yes,
scheduled.
Yes, ma'am.
So if there are questions, I'll surely answer them if you just SMS them or message me, because I really apologize, I can't be there now.
Yes, ma'am. No problem. We totally understand, and thank you so much for your for giving your precious time in all
Yeah,
your.
thank you so much.
Thank you,
Thank you
ma'am.
so much.
So we will move forward. Now we will look into good surgical practices. I hand over the mic to Dr. Monty Khajanchi. Sir is MBBS DNB General Surgery. Sir is Associate Professor at Department of General Surgery, St. GS Medical College and KEM Hospital. Over to you, sir.
Yeah, first of all, let me see if I'm audible because there was some mic issue for
Sir, you
us.
are
And
clearly audible now.
okay, thank you. So first of all, I would say you should all kind of applaud or say thank you to Boris and Harsh who's taken this initiative for the second year. It's for me. It's the first time I have heard about it, orienting the second years before they go to their posting. But that's these are. I'm sure Boris is a very sensitive person. What difficulties he has been through, he doesn't want his juniors to go through, and that's how it should be. That probably it's not benefiting him, but it's benefiting the next generation, and that's what is all about. How you kind of Modi kya karega? Modi to mar jayega ek din, but then he's creating, he's doing a lot of work sitting in that chair, and for the generations to come, and changing the culture and changing the society as a whole. So thank you, Boris, and thank you, Harsh, for taking this initiative. So my lecture is, or my talk is not going to be too long. I think Dr. Shraddha and ma'am have kind of said a lot of things already, and so I don't know how well because it's the first time. Uh, Certain things I think is good I can communicate on this platform, but at the same time, not all can we can cover all the things on this platform. So just kind of walk to any of the concerned surgeons regarding if you have any difficulty during your posting. So yeah. So orientation to clinical posting. So when you say surgery is a little bit scarier than medicine or other things. It's what happens inside the operation theater. No one knows actually, and what one should be doing. Do you read books and this? Every operation theater or any OT would have its own culture. And what happens to surgical patients, the wounds? Do we touch them? How do we touch them? All these anxieties are there. Unless you have a family full of doctors and surgeons, I think this anxiety will be there. Uh, Whether you take surgery or not, it is a part of your curriculum, and I think it's very important in terms. Even if you don't take, I think it's more important because to have some knowledge of surgery is most important because as a doctor, people don't see you, okay, in your silo of you're a neurophysician or you are some kind of a hematologist or you're some kind of a neurosurgeon. They will say doctor है ना, तो उसको सब आता है. So that's the general perception. And believe me or not, you will face that you might be the top transplant surgeon, but they will come to you as a family member for sardi, khasi, bukhar, the basic things also. And you're like, अरे मेरे पास क्यों आ रहे हैं? मैं तो transplant surgeon. So similarly, any wound injury, if you are a doctor, they will be coming to you and saying, "इसका क्या करना है?" And you might be a hematologist. He probably doesn't know anything about a diabetic foot or a wound, but he'll come to you. Not that you have to give advice, but you will have to guide them on the basics at least. So having this basic knowledge of surgery is most important. So what I will try to do is I'll be just quickly going through what are the different avenues you come across or parts during a clinical surgical posting you would come into. What is expected out of you in each of these parts? What you should be reading and coming to these things. What are the priorities? I think priorities is my summary slide. So these are things. Quickly, the surgical lectures. I think these are common to everyone, and though they are boring, I personally find lectures very boring. But for attendance purpose, you may have to. But you should try not to learn everything from the lecture. Though they are 1 hour lecture, or they are probably 45 minutes, 1 hour lecture. But you will learn 3 important points. One of the other things I see is lectures is people will try to make notes of this. There is immense material out there, digital. You'll get notes printed. You'll get books of various books, and its accessibility to these books have increased. During our time, there was nothing like a mobile phone also. So imagine there is mobile phone had just come in, and imagine having a mobile was like it's a luxury. So now with mobile, with laptops, with everybody, with PDFs, with easy access to books and documents and everything, I don't think so you have to make notes. At the same time, not if it's helping you write, because that's important. If it's helping you write, not because you have to write your exams, but how you write in your prescriptions, how you kind of explain people by writing. In general, writing is important. So if it's helping you to write, do it, but don't make notes of the lecture continuously, is what I would say. Listen to the lecture very careful. Only jot down some important points which you have to go back and read if you didn't understand, or if the that person says read this in more details, or if you didn't come across this anytime, or there is a doubt in your mind, you go back, you write this. So make very summary points. I don't think so it should be more than 5 to 6 lines after each lecture. So otherwise lectures are boring. You may go to sleep, which is fine. But at the same time, we still the systems have not changed of this lecture pattern. Best I would say in lectures is that you come to the lecture, you read and come to the lecture. That's the best way you can maximize the lecture's benefit. That's the only point I would say. Read and come and ask questions. Ask the most silliest question. Make mistakes. These are the only things I would say for a lecture. Come ask. You don't expect that the person who is talking there knows everything also, but it induces us to read, come back to you, and give you the right answer if we don't know. Okay, so please do read before a lecture. Maybe for 15 minutes, maybe 30 minutes, maybe you forgotten, you had a party last night, you were supposed to read, you didn't read, but on the way to your hospital, take out your mobile phone. Your access is so good now. Take out your mobile phone, browse through up to date, browse through something else, whatever notes, lectures you have, browse through that, listen your podcast. You have so many materials now, but read and come and attend and try to get 2 or 3 points. If you get 2 or 3 points, lecture is well attended, I would say. And jot down some summary points to go back and read. So yeah, we'll come to the other aspects of rounds, clinics, discussion, surgery in the OT, what happens, emergency room attending, and skill learnings. So before that, as Shraddha ma'am has said, it's a unit system in big departments. Smaller department may not have units, or they may have 2 units only, but we have 8 units in general surgery with different head of units. So the head of unit is generally a professor or an associate professor, and over all these heads is head of department at the unit. As there are around plus and minus keeps happy as one of the biggest department, as far as my knowledge goes, what I have read, or it may be close to number 1, 2, 3. We have 8 SRs. They are senior residents. Once they finish their residency, these are those people, and they are the working horses, I would say, along with the residents. And OPD and emergency is generally on the same day for us. So when you have your morning OPDs, it's the same day we have emergency. So that's the busiest day for that unit, the residents as well as the consultants. OT is in a week, 2 days. We have OT days, and as I said, we are one of the biggest department as far as my knowledge goes. So why faculty whose residents, whose SRs, just so that you can approach them better and make use of all of these people better. I'm telling you, the residents, third year, second year will be your point of contact. They will be teaching you the most if you kind of gel with them best. Okay, so I've been all these evening clinics. What Dr. Shraddha was saying, residents will be taking place. They're very happy. The exam going residents are very happy to take. It's kind of their revision going on. So approach them, keep them in the loop, take their contacts, be in touch with them. SRs are also preparing for future exams or something, or they are nicely read now, so they are most happy to take. So these are the people you should be contacting for your clinics, I feel, for your evening clinics especially. But that does not decrease the importance of the professor. So what the professor is coming is with, or associate professor is coming with, a 20-15-20% failing again coming. So he will give you that that juice of those 30 years probably in that 15 minutes, 30 minutes, an hour you spend with him. So those are very important. That juice or that whole lecture is very important, I feel. Typically a resident or an SR will be giving you fact based, whatever he's learned across or he's read across, he'll give you. So, but the professor, he will not open a book. He will just talk and talk, and he can go on for hours just because 30 years he's got so much to talk. But somewhere you have to tell him, sir, we have to go for another lecture, so that he keeps okay. We'll take this next time. So moving on. So during your surgical rounds, what are the different things you will see? So these are different variety of cases you will kind of see is general surgery, and you will see cancer surgery, you will see breast surgery, diabetic foot, trauma, neuro, cardio. All of this is there, but they are in different departments. But these are the basic things what you will see across is all kind of general surgery and GI surgery, benign as well as cancer, elective as well as emergency. So there is a huge variety. Trust me, you've done residency or you've done your undergrad training. Please make use of these wards, which are filled with variety of cases. You will find everything out here. Just you have to be talking less, hearing more, observing more. There are lots and lots of patients out here. You will not get the same benefit anywhere else. Trust me. You go to the UK, US, you will be struggling to meet a patient, struggling, okay, to touch a patient. Here you can go, talk, touch, auscultate, palpate, everything you will be able to do. So trust me, make best use of this clinical postings, 1 month, 4 weeks, 6 weeks, whatever you get. And when you are in a surgical clinical post, read surgery, read surgery. You might have ENT, opthal, PSM, pharmac, other things on your mind. But make a time so that you read for 1 hour, 2 hour surgery also. Because that is the best time you will know. You see that patient, you come back, you read about it. That's the best thing you can do. Don't start reading transplant, some abstract thing here and there about surgery. Try to read the basics and try to read the clinical cases, what you have seen and done and palpated, or you're going to take a history or attend a lecture. That is the best deal you're going to have. So surgical lectures, I think we've covered their schedule, different topic from basic to organ and disease specific. Read the topic at least once, have a few questions, headings, subheadings for various topics, multiple books, standard book first. So yeah, the last 2 points I'll just touch upon, headings, subheadings of various topics. So this is to do more with the exam point of view. Most diseases, most topics in surgery or in medicine overall can be divided into headings and subheadings. Okay, there will be headings and subheadings like in your anatomy, because you've done finished first year. There will be some kind of general data or epidemiology. What are the facts which are there? Then there will be something like the relations to that organ, anterior, posterior, medial, lateral, the function, the blood supply divided into arterial, venous, lymphatic. So this is a structure which is there. Similarly, many diseases will have a structure, or many conditions which are mentioned will have a structure, starting from how common it is, the epidemiology, whether it is found in India or not present, the most common symptoms, the less likely symptoms, What are the signs you kind of demonstrate? So these are all the various headings, subheadings. So if you kind of do it for any cancer specific question, you will have 10 points which you need to remember. Keep those heading in subheadings in your mind. You will not run, you will have enough to write into it. Just remember the 10 things, you will have enough to write into it. Your answer is complete, your paper looks neat, you're done. Okay, so this is just a simple point from the exam point of view. So read multiple books, but try to make a summary in one book. Because when it comes to exam time, you can't read multiple books. You will read only one book, maybe Bailey's for surgery, read that book, make all the other from other books, whatever data you have captured or whatever points you have captured, kind of write it and put it and paste it into that one book. Those are few tips from the surgical round. This when is when we kind of the resident, then we kind of say do this to the patient or what surgery it is, it's on will kind of give you. This is one thing I would say, prioritize, attend professors round, associate important. You may get bored, you may not be able to hear sometimes. Ask questions, look at the x-rays, look at the drains, what is coming out of this body, look at them, ask questions. There are multiple tubes, there is a chest tube, there is a bile duct tube, there is a teeth tube, there are Foley's, there are other drains which are coming out. What are this, what is the color of it? Discuss with the resident there or discuss with the professor there. If you ask, it's going to be more interesting for the professor. Otherwise आप आए हवा के झोंके जैसे और आप गए हवा के झोंके जैसे, it's going to make no difference to anyone. So please make a point to ask questions. Look at the post-op complications. You see a lot of complications happening. It's a big, huge ward. There are 240 patients. Surgery like driving, you're on the road, you will bang a car, you will touch someone. In the busy road, you will happen. Okay, similarly, like surgery, they're bound to have complications. So look at those complications. They can be disease, they can be organ specific or operation specific, or there can be general complications. So look at them. So this is till you see them in the ward, it's not going to be. It's no book can cover it. Pre-op assessment. How does a patient gets fitness for surgery? What are the different things you need to look? If he's a diabetic, if he's a hypertensive, he's a cardiac patient, he's a nephro patient or a kidney disease patient, he's a hemat patient, he's been having bleeding disorders. What are these different things what you have to look into? So this all comes into your pre-operative assessment. Very important. Again, this all gets covered in the rounds. No books will. Again, I'm saying no books will cover it. So rounds again. How the resident kind of summarize or presents his history, shows the examination, how the consultant kind of examines, what are the diagnostics they look into or discuss. All this will be covered in your rounds. Again, the few important things not at your level, probably at the PG level, are important. What antibiotics are going, what is the nutrition of the patient, is there a differential diagnosis or we have clinched the diagnosis, can we move ahead with the treatment part, and how is the physiotherapy of the patient being done post surgery. Okay, another important topic I think Dr. Shraddha also had insisted is surgical clinics and discussion. This is purely dialogue and interaction. You kind of present the case, a short case, long case, instrument, whatever it is. Maybe it be bedside or in the side room. But there is where the activeness from you guys would come into the passive mode. Most of you I feel are passive. They too present kar, too kar. I keep telling them what is going to happen here. Let your mistakes happen right here. It is very important you make mistakes here. Then you go to your exam or to the real world and start making mistakes there. Make your mistakes here. The moment you utter a word, you know how you're going to say it in your exam. Okay, but get all that shyness off. Whatever you want to do, have a caffeine, have a beer or something, but get all the shyness off. Come and present case. I feel if you're 15 posted in the surgical post, all 15 should make an attempt to at least present one case. At least present one case. May it be history with examination and differential diagnosis and all that, it will come. As you go into the clinical postings, these will things. But the important thing is to make an attempt, present, and discuss. That's the other thing. Once you present, I will ask you one question, it will make you think. Your gray matter gets activated. Otherwise, you are so passive. You're just, think. You're just when you're reading again. Only reading in the library is not. It's not going to help you out. Till you read and come out and discuss with the others who have read, that will add more value. That will make it more richer. So discussion. You might read 10 books, but till you don't discuss, that whole richness of that matter is not going to. So try to attend, present maximum, make mistake, discuss if there are no topics. Suppose that day no cases are there. Meet the resident, meet the consultant, ask sir, can we discuss hernia? Discussion means it has to be from your end. What do you know in hernia? What you don't in hernia? What are the surgeries? Let's have a surgical discussion. Why mesh? Why no mesh? I'm just giving you an example. There are so many things to discuss. From minor things, I mean, from small things to major things. What kind of surgeries are done? Are there different approaches? But if you read, you know this. So best is to discuss. If there are no topics, you come have a discussion. Try to make use of each day of these clinical postings. So prior reading is needed, art of making a diagnosis and based on history and or examination. So I think it will come eventually, but initially I think focus on history. What are the different components of history? What are the symptoms? What are signs? How do you do examination? If in your second year you could take a good history and examination and come to some basic diagnosis, you have done your second year. You are good. You are perfect. Kaam khatam. You have 2 more years. Then you start making differential. Then you start discussing about diagnosis and the diagnostics to be done. X-ray, CT, A, O. You will see a lot of things going on. But if you know a basic history and a good examination with different clinical signs to elicit, I think your second year work is done. Coming to a differential diagnosis, you are super, I would say. Then, if you can come to a good 2 or 3 differentials, you've done super. Again, discussion is the key. Okay, so Pauras told me to go very much into this thing, and though I feel we teach you during the surgery a lot, but he had this whole hiccup that when he first entered surgery, he didn't know what is to be done. So I don't know how much I'll be able to cover onto this because time again is limited. I'm overshooting it, but I have 2 more slides. I'll go fast on the surgery in OT. So different zones are there. So when you enter the OT, there is somewhere you put off your slippers. Before outside the patients are waiting, the next case is waiting. You will put off your slippers. Then you walk inside into the changing room. So you will need to carry your own changes like the scrubs. So it's much more interesting now because now you're going into the real medical world. So this is what I would touch upon because I'm running short of time. Emergency room attending, very, very, very important. Don't attend clinics rounds, but those units will have emergency duties also. Very important, though not compulsory. To emergency in a posting, you should be attending at least 4 overall in your surgical post. You should attend 4 emergency duties. Best time is to attend is evening and overnight, 6 to 8 hours if you can attend because that's the maximum load of cases you get. How they walk in, how the junior person sees him, sends him for investigations. How do you kind of stabilize a person, resuscitate? How do you give fluids? All these things, different aspects you'll do. Whether he needs surgeries, not doesn't need surgery. If he needs surgery, how he's getting rolled into the surgery. You carry your scrubs and all the mask and everything there also. You can attend the emergency appendectomy, perforations, obstructions, all these kind of surgery, or a diabetic foot deprivement and stuff. So very important, essential. You will get a different kind of perspective altogether. Very different. The emergency room is very different from your wards. So yeah, carry with you the clinical examination book, aprons, stethoscope, and OT changes. Okay, apron because then people know you're a student. Apron pera hai, doctor hai. So that becomes you don't have to answer, keep answering everybody. So skill learnings again, minor OT attending, basic of needles and suture. Look at what sutures are being used on the skin, on the fat. How are suturing being done? Look at the skill videos, YouTube videos. A lot of them are available. How is knotting being done? Do these basic things because they'll help you in your internship and if you take up surgery later on also. Even if you don't take up, as I said, it's very important. You don't know where you'll end up in your next future. Basic surgery like CLW, small swelling, circumcision, hydrocele repair. Try to look into the minor OT for all these things. These are all skill learnings. I think it's important. Touch the patient, put an IV line, do a CLW suturing if you can in your second year. It's a different kind of a feel you'll get, and you will never forget this. So these are things I would say summary or prioritize clinic, OT and rounds, emergency rotations, discussions with your colleagues, with your seniors, with residents, with the professors, discuss. Let us know what you want in lectures. I am not a very lecture person. It's less on my priority. Self-study and interactive. That's what I would say is more important when it comes to theory. Anything if I have missed, you all can let me know. I'm stopping. Stop sharing.
Thanks
I
a
hope,
lot, sir. It was
I hope I
very
was audible and sorry to overshoot the time.
Sir, it's okay. It was very practical and very nice. So we'll move forward. Has Shriraaj sir? Yes, sir. So Shriraaj sir will be presenting next. So Dr. Sreeraj Talwadekar, sir is MBBS MD Microbiology, Assistant Professor at Department of Microbiology, SET GSMC and KEMH. Over to you, sir.
Yeah. Am I audible?
Yes, sir, you are audible.
And PowerPoint is visible?
Yes, sir.
Yeah. So at the onset, I'd like to thank Pauras and Harsh both for giving me the opportunity to talk. And also, I'm thankful for Shraddha ma'am, Sujata ma'am, and Monty sir. Very nicely, they took me back to the memory lanes, made nostalgic about the community medicine posting, and surgery posting. So it's a good initiative by Pauras and Harsh, starting such kind of lectures for the people who have just reached second year. So I'll start. All the speakers have nicely explained what you are going to face or kind of expected to encounter in your various postings. But this topic is slightly related to the practices which you should follow when you will be doing these postings and almost throughout your life henceforth, I guess, because you are going to be a clinical doctor for the rest of your life. So whether it is medicine, whether it is community medicine or surgical postings or any other field per se, you will need to follow some of these concepts which I am going to cover in this particular talk. I'll try to keep it interactive since it's already been some time that you guys have been waiting. So once again, welcome you all. This is like a transitional phase for you from coming from 12th standard to the medical curriculum, from the phylum Serenterata and Pteridophyta and whatnot. You entered the medical world, and now you are going to, in fact, enter the clinical world. So that is completely different. You will understand, you will realize that very soon from your bone set of the first year anatomy. Now we are going to actually move towards the patients per se. So basically the transition is more like from the normal to the abnormal. First year, what you mostly learned was the normal things, more the anatomy of a normal person, physiology, entering the multiverse of madness. obviously it is madness because you are going to see so many varied presentations of various elements. So it's not going to be static, it's going to be very much dynamic, just like parallel universes and various timelines. And but obviously this multiverse presents a lot of opportunities for you to learn to look out at the various new aspects of medicine as you know it uh, from the first year. So the objectives of my talk is basically to demonstrate the correct technique of hand washing. I'll need your help in that as well regarding the proper use of personal protective equipments, how to handle sharps and its disposal, and what is the post-exposure prophylaxis. So these concepts which I will tell you about today, it will be also covered in your second year, obviously in terms of infection control, but this should stay with you for throughout the lifetime. All the three speakers, I am sure they are implementing this in every day of their hospital work, whether medicine or whether it is surgery. So, what used to happen before COVID-19? We used to keep many lectures and talks on hand hygiene and use of personal protective equipment. What these many of the departments used to say, "ये मेरा expertise नहीं है, I am out." So this was a very common picture. Unfortunately, I agree. They have lots of patients to see, and the priority for such topics was almost at the back. And they used to say, कि, what should we do? अगर हम क्या 200 patients देखे कि hand hygiene सीखते बेटे, कि N95 कैसे डालना है ये सीखते बेटे. So that was the picture before COVID-19. But what happened after COVID-19 or since COVID-19 is only Bunty bachne wala hai. That was the lesson learned from Corona. So basically, the fear of COVID virus has actually taught more than what we infection control specialists have been trying to teach since almost 200 years. So the advent of hand washing by Semmelweis was almost more than 200 years ago. So this is the story. Hopefully you will take this in a positive way, because this is the need of the hour per se, not just because of COVID, but also other infections which are always present there in a kind of healthcare associated settings. So what do we do for it? You have to follow universal safety precautions. What do we mean by universal safety precautions? Is mainly these are against the blood-borne pathogens. That is, to name a few, it is HIV, hepatitis B virus, hepatitis C virus, and other such blood-borne pathogens. So they are present mainly in the blood and the body fluid. So there is a concept of universal safety precaution, and there is a concept of standard precautions which extend beyond the blood-borne pathogens. That is known as standard precautions. So what are the components of universal safety precautions? Mainly it is the hand hygiene. Very simple, but many of a times neglected aspect, especially pre-COVID. Now it has changed a bit. Then you have to follow the barrier precautions. Safe handling and disposal of sharps is very important. Management of spills, and lastly management of exposure, which is a very, very important thing. You should know what to do in case you are exposed. You may not get that much exposed in the sense to the pathogens. You may not get a needle stick injury probably in the second year of MBBS or even the third year or final year, but yes, during internship 100% many of you might end up with a needle stick injury. So you have to keep these concepts very much in mind. So hand hygiene, everyone knows about it. What is there to teach about it? You'll think on that terms, ye kya sir sikha rahe, haath kaise dhone ka, are humko to sabko malum hai. But where is the facility in the wards? If you see, the sink is very bad. It is stinking, not clean for many days. The soap has been used by Ramesh, Suresh, Naresh, anything of that sense is required. But you should always remember that the technique is more important than not the agent which you use. Like I said, you can either do a soap and water hand wash or an alcoholic hand rub. But what you use is not important. The technique which you use is very important. You have to cover all the parts of your hands to make it an effective hand hygiene method. So only thing you need, only aspect you should know is that you cannot use an alcoholic hand rub in case your hands are visibly soiled with either dirt or organic matter like pus or blood, etc. So always at the end of the shift or while going home, it is preferable that you always use a soap and water hand wash rather than an alcoholic hand rub, which will not act in the presence of organic material. So these are the areas which we frequently miss out during hand washing. How do we do hand wash? We just open the tap, we take the water, and we do like this. That is what you do in your daily day-to-day practice, right? Before having lunch or before having any meal, and after having meal, what we do is we just open the tap and we just rinse it with the water. And this is what happens. It is what is most frequently missed is the these are the parts of your hands which are frequently missed, and they will have this hospital acquired organisms, like typical example being the methicillin resistant staphylococcus aureus, also known what is known as MRSA or MRSA. So this is going to spread not only to the other patients, but also you might go back home. You might have some elderly in the family or a child in the family who are not that much exposed to such kind of hospital bugs, and generally these are highly resistant to antibiotics, so they cause serious infections and need higher antibiotics to be cured. So we have to be very careful. So what is the correct way to do hand hygiene? Can anyone demonstrate? You can keep your cameras on if the bandwidth permits, and everyone will do it with me. Please, can some of you start your cameras? Anyone who starts the camera will get a chocolate from Pauras, not me, of course. Yeah, good. Someone has, only Harsh has done. Harsh wants the chocolate desperately, I guess. Anyway,
Harsh wants the 5 marks in microbiology practice.
Yeah. Okay, we'll make a provision for that as well. So we'll start because the time is not permitting. So what you have to basically do is for a hand wash with soap, what you have to do, see, the technique remains more or less the same, only the agents will change. What the steps are, you have to start the water, make sure that you take enough soap and lather it such that it covers the whole of the hand. Now everyone will do with me, palm to palm, back of both the hands with interlacing the fingers, and you have to do in between the fingers. You have to do the knuckles, you have to do the thumbs, and very importantly missed is the fingertips. You have to, many a times in the nails, beneath the nails there is a lot of dirt, so you have to do both the hands, the fingertips, and lastly the wrist. So very good. Now always whenever you do the hand hygiene, even if it is before and after your meals, you follow this so that it comes to you subconsciously. So this will really help in preventing the hospital acquired infections by as high as 50%. And what is very important, that you should not have any kind of ornaments or a ring, etc., and your cuff should be folded. So this is the same for whether it is an alcoholic hand rub or this soap and water hand wash. For alcoholic hand rub, you have to take at least 2 pushes of the alcoholic hand rub so that it covers the entire hand, and till it dries you have to keep on rubbing. So the time taken for alcoholic hand rub is up to 15 to 20 seconds, and time taken for a soap and water hand wash is 45 seconds to 60 seconds. So तेरा साबुन slow है क्या, fast है क्या, कुछ मालूम नहीं. You have to do it for 45 seconds at least for it to be a effective hand wash. So this was how to perform hand hygiene. That is the technique of hand hygiene. We should also know when to perform hand hygiene. What is classically known as 5 moments of hand hygiene, which has been given by the WHO. So it is very easy to remember. You have to always wash hands when one of these 5 incidences occur. So that is before touching the patient and after touching the patient, which is very straightforward. Then before doing any kind of aseptic task like blood conduction, phlebotomy, any kind of task you are going procedure, aseptic procedure you are going to perform on the patient, you have to do a proper hand hygiene. Fourth is the after exposure to body fluid or blood, that is after the risk exposure, you have to immediately do the hand hygiene. And last is the very often missed is after contact with patient surroundings. Now Monty sir said, Shraddha madam said, Sujata madam said, everyone said that you are going to go and see the patients or going to see the families in the community. What happens? You just go in the wards and you nicely chat with your friends and go and sit on the patient's bed. Sometimes you touch the patient's file, you touch the patient's trolley, you touch the IV set stand, etc. And all these are likely to be contaminated with very resistant bugs, like very resistant hospital acquired bugs, and this is going to become a part of your residential flora of your transient flora of your hands. Transient flora means it is just on the superficial layer of the hands, and then you might transmit it to your family members or the other patients when you are going to touch the other patient. So this is one of the modes of transmission. So never forget, even when you touch the patient's surroundings, after that you have to do the hand hygiene. So these are the 5 moments you should never forget: before and after touching the patient, before doing an aseptic task, after exposure to body fluids like CSF, peritoneal fluid, pleural fluid, or blood, and fifth is the after contact with the patient surroundings. So what you can use, obviously you can use, like I said, an alcoholic hand rub. Betadine scrub more for a surgical hand wash that extends up to the elbow. I'm sure Monty sir will tell much more in detail. You can use a normal liquid soap or a bar of soap, which is being used common to all of them. This is more likely to be avoided because it is kind of sharing the pathogens with the others. Why to wash hands? Like I said, it can result in reduction of hospital acquired infection by as high as 40 to 50%. So that's so important. And like I said, transmission of MRSA from one patient to the another. When you palpate one patient, and suppose you don't do hand hygiene, and that patient has MRSA in the skin, then you will transfer the MRSA from one patient to another. So please follow this very sincerely. Next I will cover is personal protective equipments. Very important concept again, which we tried to emphasize on, but wasn't captured that much. But now during Corona, now almost all of you are aware what a PPE is. Most of you will confuse a PPE with a PPE kit, which is the entire kit, different types of PPE which come in the form of kit, and personal protective equipment are the individual components of it. So only glove is also one PPE. So if I wash hands, why should I wear gloves? Obviously, gloves acts as a barrier between the organisms and your own body. Minor cuts are always present on your hands, which might be invisible. Intact skin is a very good barrier, but yes, there are some minor cuts which you may not be aware of, and they might be present on your hand. And when you glove the hands, there is very favorable atmosphere for the microorganisms to grow. And when you remove the gloves, there will be more chances of more bacteria in your hands. So you have to again wash your hands after removing also. So this is what the components of PPE kit will be there: that cap, goggle, mask, gloves, and either a plastic apron or a cover also, depending on what kind of activity you are going to do. So this will protect you against splashes. So very important, you might encounter a lot of splashes in your clinical posting, especially in something like a gynecology or obstetrics, or even the surgical posting. So you have to be very aware of that. Like Shraddha madam already said, you have to wear complete covered footwear, like proper shoes, not your paragon or your open floaters and all that, or chappals. Please don't wear that when you're doing clinical postings. So this is what you have been aware of in the last 2 years or so. A complete coverall suit, N95 or a surgical mask. This showing a surgical mask, your gloves, face shield, shoe cover, and your head cap. So for this, I'm not going to go in detail much because the donning and doffing will take a lot of time. You can go to the YouTube and just search RRC KEMH donning and doffing of PP, or you can just search donning and doffing of PP. You will get many results. You can see it by yourself, how to don and doff. What you mean by donning is to wear, and what you mean by doffing is to remove. Only concepts which I will stress here is just remember that while donning, very important thing, if you are going to be posted in a COVID war or where you expect aerosols to be generated, you have to do a seal check of your N95. When you are worn the N95, you have to just puff outside. No air should leak from up or below. And when you inhale, the N95 should collapse. When you exhale, the N95 should come back to its original shape. That means your N95 is properly worn. This is very important. This is known as the seal check or seal test for the N95. And while doffing, you have to always remember that your outer and front side will be most contaminated rather than your back side and the inner side. So first thing you have to do is the hand hygiene. After you have finished your clinical work and ready for the doffing part, that is the removal part, you have to first remove your outer gloves always, because you have touched the patients or you have done some procedure. So your outer glove is most likely to be the most contaminated, and everything else you have to remove from the back side without touching the front. You have to remove your face shield, you remove it from the back. Don't touch the face shield's front. Don't touch the goggles front after you have done the clinical activity. Don't touch your N95 from the front if you have done a nasopharyngeal swab collection or you have done a bronchoscopy in your future, maybe not in the clinical posting. So always remember your front will be contaminated. So you remove it in such a way that you do not touch the front, remove it from the backside and try to remove it inside out. Like the coverall suit, you will remove like you will remove with minimal touching of the front, you will remove it like you remove your shirt. It should come inside out. This inside part should come outside so that the contaminated part will go inside and the one who handles the waste will not be exposed to the pathogens. Okay, again gloves, you will, this is all there in the video. Gloves you will remove inside out so that the contaminated part goes inside. So this is very important, you should note this. And so just a random quiz I'll take, if I get some responses from you. What type of PP would you wear if you are suctioning oral secretions? Anyone in 10 seconds? Come on. Any responses? What do you expect to have in oral secretions? So obviously you will need a mask or a N95 or surgical mask because you are going to get some kind of aerosol. So N95 is preferable, and a face shield to cover your mucous membranes, that is the nose and the mouth. And sometimes if you are think that splash may come, then you have to use a gown. When you are responding to emergency where blood is spurting, so Dr. Monty already told you about emergency postings. You have to see this kind of atmosphere to believe it. It's like order in chaos. Literally, everything is going on. There are blood spurting from here and there. Trauma cases. Just now, patient has come from accident. There is a ripped artery and blood is spurting everywhere. So what will you do in that case? You need gloves for sure. Wear double gloves if you want. If they are providing you, you need a fluid resistant gown. Like I said, gynecon ops where blood might spurt, or your surgery medicine, surgical fields. And you need a face shield, obviously, to protect your exposed mucous membranes, which is your eyes, your nose, and your mouth. Drawing blood from a vein, that is phlebotomy, you might not need, especially if it is a venous collection, you might not need anything more than a gloves. In current situation, you need a mask because of the pandemic, but otherwise you would have just needed a gloves. This is known as rationalizing the personal protective equipment. So don't say कि मेरे को phlebotomy करना है as an intern to give me the entire kind of N95 and all that coverall suit, etc., etc. So this is known as overuse of PPE. You had seen this during the first and second wave. People were using personal protective equipment to conduct marriages and all. And again, when you are doing clinical work, you have to keep your mobile phone aside, your food material, everything aside, and you will not touch it with personal protective equipment which has been used on the patient, because it was going to lead to transmission of the infection. So very important aspect again is safe handling and disposal of sharps, especially during your internship. Believe me, most of the needle stick injuries we get, about 80% of them are interns. They might not be second or third year MBBS student, but yes, certainly interns and nursing students, they are mainly there in the needle stick injury column. So when does it happen? Either during use or mainly during the disposal. This is what happens very commonly. Take a pledge, take an oath right now that you will never, never, ever, ever recap the needles. Whatever happens, you will not recap needles. When you will do start internship or anytime you experience the use of a hypodermic needle, you will not recap, even if it is on a VIP patient whom you think might not be suffering from HIV, HBV. These diseases do not discriminate. So you will never recap. So if I am telling you do not recap, then what will you do? So not even the single hand method. There is one single hand method which you will try again. There you will get a prick. So you will not do this either. And always pass the sharps in a kidney tray or some another container. Especially for the nursing, this is important. So never pass a scalpel blade like this to your colleagues or whoever needs it. You are always pass it in the container. So what you need to do is dispose the complete needle and syringe as a complete assembly into the puncture-proof sharps container. You do not try to recap. Just put it completely as a single piece in the sharps container, provided it is puncture-proof. Or what you can do is there is something known as needle cutter. You can just put the hub of the syringe in this and just squeeze these levers, then that hub will cut, so the sharp will fall in this metal container. The remaining syringe, plastic syringe, it is infectious, so you can put it in the red biomedical waste disposable bag. So you will see this in the wards lot of time. The sharps container, there is no lid, so that is a very big problem. Suppose someone kicks this by mistake, everything, all the infectious material will come outside and might lead to transmission of diseases. Again, this should always be avoided. We see this lots of time, overfilling of the sharps container. The interns come, they put it, and the labor staff does not bother to change the container for days. So what the interns do, they just shake the container like this, and again they keep on filling it with the whatever available space it comes. So always get the container changed when it is 2/3 filled, and it should never overfill. You can see here, you can see blood stains on the wall as well. So this might lead to transmission of hepatitis B, hepatitis C, or even HIV. So what do you do in case of management of spills? Suppose when you are doing internship or during your clinical postings, if you see a big patch of blood on the floor, what you will do? You will just wipe it with your shoes and go run away from there. मैंने तो कुछ किया नहीं है, किसी ने मुझे देखा नहीं, right? So that is not what you need to do. When you see a spill, first thing you do a spill or see a spill, first thing you have to do is alarm, raise an alarm. Do not panic and raise an alarm. Tell your whoever there is there around you that there is a spill here, so that they do not get exposed. Then you can assign a person for cleaning it. The labor staff can do, or you can yourself do. First, wear the personal protective equipments. Then mark that area so that no other person comes to that area. And then you have to pick up with forces. If there are any sharps, pick it up and put it in the either the cardboard box or the sharps container. Then you place some absorbent like cotton or gauze piece on that and just lift it up and put it in the yellow bag. Why this is so? Because your disinfectants will not directly act on the organic material, that is blood, etc. So always first lessen the bio burden or at that place, and also the organic material by placing the absorbent, and then again put an absorbent, put sodium 1% sodium hypochlorite, and keep it for 10 to 15 minutes, and then you do the normal mopping. Otherwise, what happens if you tell the labor person ki idhar spill ho gaya, he will come with that chindi, the mop, and he will start washing, cleaning it, and then it will, he or she will spread it all over the normal area. He will use the same chindi in your lunch room, your residence room, your doctor's room, everywhere, nurse's room, and it will transmit all the infections. So this I have already told you, you have to keep it for the requisite contact period of 10 to 15 minutes minimum. Don't just put it and just lift it because of lack of time. And lastly, you have to do the mopping. So what about the management of exposure? What happens if you get the needle stick injury? So what first thing you do not do is don't panic. Don't panic. Don't think this has happened. You might think what sir is saying, ki panic kya karne ka? This has happened to us. This has happened to our colleagues. This has happened to many interns. When we get a prick, what we think is, "Arey, HIV hoega, hepatitis B hoega." Don't panic. There's no need to panic. Secondly, don't press the finger. Don't think this is a Bollywood movie. वो सांप काटा है तो इसे पूरा poison निकालना है. No, you don't have to squeeze. What happens when you squeeze and release? There is capillary. There is negative pressure in your capillary, and the virus will go further inside the bloodstream. So don't press. Just start the tap. Wash it under the running water. Let it bleed. Let the blood bleed. When your bleeding time is over, it will stop bleeding. Cover the injured area if it is a large cut. And very important, very important is inform your senior. Whoever is there in the posting, just inform them, whether it is someone from the hospital side, not your senior, means not your senior MBBS student, but someone, the sister in charge, the resident doctors, or the assistant professor, or like Monty sir said, anyone who is there, senior is there, inform them. What happens? You will think that no, I don't need to take the ART, but you have to inform them. It is very important. Once the bus is missed, then it is missed. Then you cannot do anything about the ART. It has to be taken at the right time. So you have to take at least the first ART, antiretroviral therapy dose, within 2 hours of exposure. What happens is after 2 hours, the virus already enters the lymphocyte. So if you take after that, the efficacy of the post-exposure prophylaxis will be lessened. So always remember, once you have been exposed and there is bleeding, you have to take at least the first dose, irrespective of the status of the patient. Please realize this. Whether the patient is from a VIP family, whether the patient is a good-to-do person, no one is immune to HIV, hepatitis B. We have seen many reports of people from so-called good families which have turned to be positive for such diseases. And always remember, for HIV, we test the antibodies. So a negative HIV report does not mean that the virus is not present in the blood. The patient may still be in an incubation or a window period, and the virus may be present, but the antibodies are still not developed. So do not be complacent in this aspect ever. So within first 2 hours you have to take. If not, then at least within 72 hours, because by that time the virus will enter the memory T cells, and then there is no use of post-exposure prophylaxis if you take it after 72 hours. So you have to do this. You have to take the ART within 2 hours and take a baseline HIV testing done preferably. And in terms of KEM, some of you are not from KEM, I think. So in terms of KEM, you'll get the first dose from ART center. This is the ground floor of the new building. You should know this because within 2 hours KEM में तो ढूंढने को ही कुछ चीज ढूंढने को ही 2 घंटे लगते हैं. So the ART center is at ground floor new building. If you had a prick at the emergency hours, that is after 9 to 4 or on holidays, or that kind of stuff, then you have to go to MICU, which is now in the casualty building ground floor. So there you take the first dose, and next day you have to report to the ART center. Lastly, for all of you guys, since you are at a nice phase of your life, it is one of the most interesting phase of a medico's life. the message for you is be careful, look out for each other. This is the fight of our lives, and we are going to win it, hopefully, whatever it takes. Good luck. Thank you.
Thanks a lot, sir. So we'll move to the question and answer session. So if anybody has any questions, they can unmute and ask. They can also put in chat sections. They can also put in YouTube comments.
Number of attendees has reduced a bit, but still those who are present and those who are actively listening, thank you so much for patiently waiting, and please do make use of this opportunity to ask all your questions, like not all means like, whatever questions related to this topic to the speakers.
I think Pauras didn't arrange for some food. That is why they left.
Next time we can, yeah.
We should have kept it in the metaverse then it
Yeah.
would have been possible.
Any questions? Feel free to ask.
Do you want us to do more such, activities? Let us know, and on what topics. How for us, the entire team, we are happy to do such type of webinars. Let us know.
If you are hesitant, you can put it in the chat box.
Come on, guys, are you even there? Just unmute and say something.
Acha, say at least okay. Don't ask questions. Just let us know how you felt or how did you feel about. Just tell us about the feedback about the program. Come on, Romil. Better you don't leave the meeting. Tell us. Did you learn something today? Pranav Bhatia, Arushi, Devgavkar. Parita is saying it was really helpful. Thank you so much. Thank you. All right then.
Harsh, you can. I think there are no questions, and
Yeah.
we should not
Yeah,
waste
okay.
time.
So I would
Just-
like to conclude the session. Thank you all the speakers. Thank you Shraddha ma'am. Also thanks to Sujata ma'am, Monty sir and Sreeraj sir for conducting this session for 2020 batch students. It was really helpful, and I know that this is going to help so much because when I was in second year and when I was going for my first posting, I didn't even know what are units. And I just went into the OPD and talked with the whoever was sitting there that I am here for posting, and that person started.
It was MMD sir for us.
Yeah, it was Mohan Desai sir ortho, and like the next day we understood that there is something called as units, and we have to go to the office, take the units, and then go to that particular teacher and everything. So you guys are very lucky that you are oriented to everything. I will like to thank all the audience who has been patient and has tagged along with this session until now. And also thanks a lot to Pauras for giving me an opportunity to conduct this. So thank you everyone. We are really grateful.
I thank speakers have been already thanked, and again I express my gratitude towards all the speakers for giving the precious time and kind efforts for this webinar. It was like in your busy schedule, it matters a lot. And I also thank Harsh for helping me out at the last moment. I contacted him and he was kind enough to help me out in this. So thank you so much, Harsh, and thank you so much to all attendees for joining in.
Yeah, for us, somebody had asked, is it okay to, if they don't understand and to disturb doctors and ask, if it's okay, it's okay. Like, if unless there is some diehard emergency, otherwise you can definitely ask. That should not be a problem. Don't keep it inside you, guys. Don't keep it. Just ask it. It's okay. You can definitely ask. Okay.
Yes, certainly.
Okay. Thank you, ma'am.
In fact, it breaks the monotony for lot of us.
Absolutely.
It gives
Absolutely.
us a very good.
It gives us a break.
Yeah.
And it just fires our neurons. That is why. So it's important. All right. Thank you, Pauras. Thank you, Harsh, and all the esteemed speakers. Lovely, lovely meet. Lovely meet. Thank you so much.
Thank you so much, everyone. I'll end the meeting here.